Okay, guys, we start now. We start
Yeah.
from cervical spine dislocations. Okay, so it's not in the order of how it comes. It's in the order of the human body. So I'm starting from top and going down. Bottom, cervical spine dislocations or facet joint dislocations are quite common exam scenarios. The controversy in that particular situation is when to reduce, how to reduce, and to do MRI or not to do MRI scan. So remember these buzzwords. But to begin with, someone will show you an X-ray of lateral cervical spine where they will be asking you to comment on what is wrong, and then they will ask you to proceed. So in this particular X-rays, this is only few places in FRCS Orth where you describe X-rays properly for 30-40 seconds. Because first of all, there is a lot to say. You need to comment about the spinal lines, the spinolaminar, anterior, posterior, spinous process lines, and all the rest. You need to describe the soft tissue shadow. You need to describe the percentage of slipping, and you need to show them that you are ready to take on this particular topic. Okay, so basically describe the X-rays. Take your time. Don't forget to talk about ATLS, okay? And come straight to the meat. If you think it's more than 50% dislocation, talk about bilateral. If it's 25%, it's unilateral. One thing, why unilateral is important? Unilateral is important because it's most frequently mixed cervical spine injury on plain X-rays. It leads to 25% and it associated with monoradiculopathy. Bilateral comes with generally with significant spinal cord injury or signs of spinal cord injury. Now, the treatment algorithm, it shouldn't be an alien to you. Everyone knows about this treatment algorithm. It is pretty much available in most books or almost all books. This I have taken it up from Miller, but you can get it from Orthobullets, you can get it from Banaskevich. You need to, first of all, as I have said, talk about ATLS, but then make sure if the patient is alert, if he's alert, you assess the neurovascular deficit. So he not only needs to be alert, he needs to be within a good frame of mind. So if he's drunk or something, then he goes straight into the MRI scanner. Yes, depending on what his GCS is, how much neurology he have. If he is alert, then whether he have neurological deficit or not. If he have neurological deficit, then you try emergent close reduction. Obviously, within the UK setting, this is one of the Bose guidelines, and we touch base at that stage. We say that we're going to discuss it with the spinal injury unit, the nearest spinal injury unit, but in the same sentence without breaking it. However, the principle of management are, or how, as Sean always say, however, we over here, we need, as it's a dislocation, we need to reduce it closed emergent, okay? Whether it's successful or not successful, you then subsequently get MRI scan and take it further. See, monoradiculopathy, remember the buzzwords, monoradiculopathy, spinal cord injury, and imaging. From here, the controversy starts. They will definitely ask you, why do you want MRI? You want MRI prior to open reduction or surgical stabilization. Why? Because it will dictate your treatment. If there is disc herniation, you will do anterior first and then posterior. If there is no disc herniation, you can simply do posterior. So if you have an MRI scan, it will tell you what to do. It also demonstrates disc herniation, extent of the PLL injury, and you can classify it. And it will sometimes show myelomalacia as well, if it's been done up, if the dislocation is chronic. But acute dislocations generally show edema, but no cord signal changes. For cord signal changes to appear, it takes around 12 hours or more. Now, if patient is in alert mental condition with monoradiculopathy, and unilateral dislocations. Unilateral dislocations are generally difficult to reduce. Why they are difficult to reduce? Because the ligaments are already intact. The PLL is intact. Bilateral, PLL is not intact and PLL is torn, and it's easy to reduce, but it is difficult to then stabilize it. So you have to have this answer in your armory. You have to say if it is unilateral and if there is no neurological deficit, I will do it in controlled environment in theaters, and will do it with sequential adding of weight, and subsequently keep on checking the neurology of the patient. Technique, as I says there, gradual increase, axial traction, addition of weights, component of cervical flexion can facilitate reduction. So you put some sort of rolled towel underneath the neck, and then you gradually provides traction and serial neurological examination. Plain radiograph, keep on taking on the lateral x-rays, and abort if neurological exam worse, or obtain MRI scan following.
Phrase I think we've covered before is, I understand the key principles are this. Obviously, yes. I'll discuss this with someone who's experienced in doing it, but these are the key principles. That, yes, I think we believe that, and again, you've got to remember that the person testing you has probably less knowledge about this than you are. It's not going to be a spinal surgeon asking you this question. So they will, as Atta says, they'll probably have a script in terms of key words of what they want you to say. But yeah, as I said, from what you've said, it does scare me like it does for us. And understanding the principles, I think, is key. And everything you've said, I can't. Yeah, you know a lot more about it than I do.
They may say it's not working with this, so any maneuver and if you're bluffing, because I would think if you're going to say I haven't done this before, say I would not attempt any maneuver. I would discuss again with my spinal colleagues, but my understanding is this, and this.
Yeah, no, that's what we said. There's a Bose guideline for spinal cord injury, guys. So you always say, I will ring the National Spinal Injury Unit or the nearest spinal injury unit. I will take their advice, and there is a strong likelihood that they're gonna get the patient across to them blue light within the next 30 minutes. Yeah. However, the principle of treatment, don't stop for them to say, imagine you are a spinal surgeon. Don't stop for them to bring up this question, because that's you making examiner talk unnecessary. And in this exam, if the examiner talk less, you talk more, it means you're going through. Anyways, we go back to the presentation. There is quite a lot to cover. So we are on this slide, guys. So over there, we discuss the close reduction. If you go to further management part, you're lucky. You then take a deep breath, because now if you're describing approach, describing in length and properly, because you're gaining marks. Okay. If they ask you the anterior approach, because of the intravertebral disc, you need to take the disc out so that you don't damage the cord as you reduce it posteriorly. You tell about the anterior approach. Don't just start rattling the approach out. Tell the steps, WHO checklist, patient positioning, image intensifier, your position, images on the images in front of you, and all the rest of it. You know that. And have a post-op protocol in your head. So have a post-op protocol as to what sort of rehab protocol you will use following this sort of extensive surgery. Generally, spinal surgeon says soft collar for 6 weeks, and soft collar only for comfort. It has nothing to do with stabilization. It's just so that the other people are aware of that the patient has got an extensive neck surgery. And it also stops neck being sore and all the rest of it. So, and then you throw few referrals, few references, if you're lucky, and if you're reaching there. Vaccaro is a big name, and Vaccaro is another big name, and he he always quantify these injuries. So if you can remember one name in spine, remember Vaccaro. Vaccaro changed the concept of spinal injury management. It has updated TLIX, everything, and Vaccaro is the main man these days. Okay, I'm gonna end the spine bit here. The other dislocation, what you get is shoulder dislocations. Shoulder dislocations, as you come down from neck, shoulder dislocations are not uncommon. Over here again, you need to describe the X-rays as it says.
We have Sahib. Sahib has a question while Artar is working on this. What's your question, Sahib?
So why can't we?
Yeah.
Hello. Yeah. Why can't we do MRI in every facet joint dislocation?
You can.
Why can't we say that actually this is a facet joint dislocation, whether it's a 25% is a unifacetal or it's a bifacetal if it is more than 50%. I would do an MRI scan as my first port of call, and this will have a huge bearing on my management planning. And to do an MRI scan, once I've got an MRI scan, I'm sure that this can be arranged whether the patient is alert oriented or not. It will give me a sense of security to reduce this more comfortably. And if there's any changes happen, I will do the MRI scan after that. Would you not say that?
Yeah,
valid question.
It's a valid question. It's a valid question. See, there is no right or wrong answer to it. And if
the reason why there's a discussion about MRI scan or whether you should do it or not is because the MRI scans are not available in every trust. Not in every hospital, not in emergency settings like this necessarily. So they will try to say, do you need an MRI scan? And you will say, my absolute indications for MRI scan are patients with altered consciousness or neurology. Okay, that's you're absolute. If you can justify why you're going to do an MRI scan, that's fine. But they will try to push you to see when you're going. If they tell you there's no MRI scan available, your response is no. In these situations, I will always get an MRI scan, no matter what.
No, but in the controversy part, I wrote how you can defend MRI scan. So you perform MRI scan prior to open reduction or any surgical stabilization. It's valuable in demonstrating disc herniation, extent of posterior ligamentous injury. So it quantifying the injury as well. It is telling you whether the spinal cord has been compressed or there is established myelomalacia. Never perform close reduction in patient with mental status changes, and when 26% of patients who fail close reduction, you then go and get MRI scan. So you can get MRI scan. MRI scan is an essential.
Yeah, no, I'm sorry, I'm not disagreeing. What I'm saying is the examiner would try and push you to say in a situation where you don't need an MRI scan, which situations would you?
Can I email it to? So the second dislocation that comes, I hope it works now. The second dislocation that comes is a shoulder dislocation. Again, in shoulder dislocation, please take your time, 20-30 seconds to describe the shoulder. That will give you time to formulate an answer as well when you're looking at the shoulder x-rays. And these are the key things you need to know, as it says on the normal shoulder PA view. Whenever someone shows you the shoulder x-rays, think dislocation, think subluxation, and think laxicity. So and you all know what I meant by dislocation, subluxation, and laxicity. Now, the most common shoulder dislocation that comes in the exam, and generally they ask, is traumatic anterior shoulder instability. Over here, you need to talk about, you know what it is. This is, and most of the time it is anterior. It is anterior. Sometimes it is posterior, and inferior is extremely common. Again, age of the patient makes a huge difference in diagnosing, and age of the patient also make a huge difference in terms of what other pathology you will find. So if it's more than 40, you can have rotator cuff tear, but if it's more than 60, rotator cuff tears are extremely common. Generally, the shoulder dislocation, when it comes and it's acute and traumatic, it's a young individual. It's a young individual whose age is less than 20, and because that's the highest risk of redislocation age, where you can have either a bony Bankart lesion or a Hill-Sachs lesion, or just a soft tissue Bankart lesion, which you have to then take the viva down to how to repair and what will be the surgical techniques. Basically, when you see a shoulder, remember to talk about all the anatomical landmarks. Remember to talk about the trauma series X-rays. So you need 3 views for shoulder. Remember to talk about the age of the patient, because that has a very strong association with what associated injury patient could have. And remember about all the other associations that can have with a dislocation. So bony Bankart, a Hill-Sachs defect, a greater tuberosity fracture. Greater tuberosity fracture can occur in elderly people, and it signifies that the rotator cuff is gone. The lesser tuberosity fracture, remember posterior dislocation. If you see lesser tuberosity fracture, it's posterior dislocation unless proven otherwise in a shoulder. So nerve injury, 5%. Which nerve? Everyone knows which nerve. It's axillary nerve. Please test the axillary nerve. As of everything, you need to start again with ATLS, high energy, low energy, describe the x-rays, remember the age factor, describe the ask for 3 views, and this. Again, any dislocation, acute reduction plus minus immobilization within the A&E setting, someone has to give patient adequate sedation, and someone has to maintain the airway. These days, the airway and sedation part get done by an A&E colleague, senior consultant, or the same level as of you, and then you relocate them, followed by some sort of physiotherapy. But a management of first-time dislocations, again, they ask these dislocations because there is controversy about it. Controversy is how would you treat it? So if it's a first dislocation, some people still like to treat it non-operatively, but generally, as a general rule of thumb, if you ask a shoulder surgeon, and for the exam purposes particularly, I will keep my indications for surgical management. If it's a dislocation happens in a patient whose age less than 20, it's a male who plays contact sports, have some degree of hyperlaxicity, and had glenoid bone loss of more than 20 to 25, then you need to have a further bony augmentation or a bony block to that. If you reach, following this, if you reach the surgical management part, then you are on safe grounds. Shoulder is not my best topic, but then if you're discussing this, you are actually passing the exam. So I have deliberately didn't describe the surgical management of shoulder dislocations, because if you're reaching up until there, then you are on the safe grounds, and surgical stabilization will subsequently be described or asked by Kashif at a later stage as a hot seat viva, and he will then be asking people as to how to augment, what is letter J procedure, what are capsular shift, what are the benefits of doing it arthroscopically, can you do it arthroscopically, or you're doing it open or not. So I'm going to finish the shoulder dislocations here and move on to the hip dislocation. But is anyone has to add anything from the mentor's side?
Yeah, sorry, Atar. Regarding this shoulder dislocation, so you need to bring the base guidelines, which is so dislocations are divided according to age, less than 25, 25 to 40, and more than 40, because the treatment is completely different for these 3 groups. So they divided less than 25, 25 to 40, and then more than 40. Less than 25, as you mentioned, they are young adults. These patients need to be seen by shoulder surgeon within 6 weeks, and ideally they should do the MR arthrogram to see whether they need surgical management. And between 25 to 40, and then more than 40. More than 40 is likely may have cuff tear, and again these may be a surgical candidates. 25 to 40 is like in between group. You will immobilize and then reassess.
Okay. I think that's a very nice upshot.
So you need to bring the best guidelines in the shoulder dislocation. So that means you are quoting the literature, you are getting the marks. And there is a very good algorithm by the best.
Important dislocation, what you have in the exam is the hip dislocation. Always remember, on hip dislocation, you should not waste any time on the x-rays. It's a hip dislocation, you talk about hip dislocation. The minute you talk about hip dislocation, you need to move fast, as there is a lot to discuss in hip dislocation. It can be an ATLS topic only. Yes, so you're talking about ATLS. It's generally fall from a motorbike or motor vehicle accident, which is a dashboard injury. So when you are gone through the ATLS, principal resuscitation, position of the limb, you have documented about the sciatic nerve, provided patient analgesia, you then start talking about the initial the radiographs. Before going on to radiograph, you can actually comment on how what the position of the limb is, and that can tell you whether it's anterior or posterior. 90% of time, if it's come in the exam, is posterior dislocation. Is posterior dislocation, like any dislocation. In this dislocation, on the X-rays, you need to comment on three things: any loose fragment, any concomitant head fracture, or ipsilateral shaft fracture, and dislocation. Generally, it's posterior, but when you call it for the when you see the X-rays and you need to say that clinically I will see the patient to make sure to comment more whether it's anterior or posterior. However, the mechanism of injury, the dashboard or motor vehicle accident is consistent with posterior dislocation. You move forward. There is generally posterior, as I said, it's 90%. Why they bring posterior in? Because it comes with posterior wall of acetabulum fracture. There are femoral head fractures. There can be sciatic nerve injuries associated with it. Up 20%. So documentation of sciatic nerve is very important. Pre and post dislocation, pre and post for post operative documentation, and post relocation documentation and pre-relocation documentation. Comment on ipsilateral knee injuries, that comes up to 25%, and examine the knee for any associated injury or instability. But that doesn't take precedence. That doesn't take priority. The priority is to relocate the dislocation. As far as what X-rays do you want, within the A&E setting, you just have an AP hip that should do, and then Mohs dislocation, you reduce it. Mohs dislocation, you reduce it with manual inline traction. While you are talking about reduction, please mention that I am aware of the fact that there is a chance that I may bring the loose fragment or the posterior lip fracture within the acetabulum, and if that's the case, then it becomes an emergency and you are required to open it. So be wary of it and say it. But I think there is no clear answer here as well. Some people say, I will talk to the acetabular injury unit and transfer the patient across. However, the principle of management is whoever is reducing the patient, whoever is reducing the hip is reducing in a controlled environment, in theaters, have all options open in case if it doesn't reduce, you reduce it open, and if there is an incarcerated fragment within the joint, you take it out, or if it's a big enough chunk, you are ready to do the open reduction internal fixation posteriorly. So you need to touch base with all these. You need to say all these things as you are discussing hip dislocation. When you talk about hip dislocation, you talk about femoral head fracture. As you talk about femoral head fracture, you say comment something about Pipkin classification. Reason being, that has to do with the vascular supply of the femoral head, and the higher you go into the classification, the more it is risk with avian incidents. I think type 1 and 2 are associated with femoral neck fracture, and if there is a femoral neck fracture, then the incidence of avian is higher. As we move down, so again, why they want to know about the femoral head fracture or contralateral or ipsilateral femur fracture? Because of the complications of avascular necrosis, because of the development of osteoarthritis secondary to incarcerated or small fragments within the articular joint, and sometimes if it's a big enough chunk of the chondral indentation, you can actually needs to repair it as well, like you repair it elsewhere in the knee or anywhere else. So these are important topics in terms of, in a nutshell. If you see a hip X-ray or a hip dislocation X-ray, talk ATLS, talk about the mechanism of injury, dashboard injury. So talk about knee, talk about the posterior lip injury, talk about one attempted reduction within A&E setting. That's what I will say, and talk about transferring the patient across to acetabular unit for further management in terms of possible open reduction, internal fixation of that small segment depending on the stability, and talk about imaging post-reduction. It is very important to have a CT scan post-reduction in that. So if you're saying all these things, you are on safe grounds. Everything else, you're just aware of it. You're aware of the Pipkin classification. You're aware of the femoral head blood supply, which is so important. You need to know, and you're aware of approaches. So again, in a nutshell, once you have the Pipkin classification, you have the blood supply, you have told about the extracapsular ascending cervical branches and ligamentum teres and all the rest. You have told about the femoral head blood supply. You have talked about the fragment, and you have done a single single attempted reduction in A&E under deep sedation. You then you are on the safe ground. You assess post-reduction CT, you transfer images to the hip unit or acetabular unit, and then they will ask you to talk about approaches. If you're talking about approaches, again, you're lucky, and you're on the safe grounds. So that's
for the open reduction. So you need to plan. So where is the fracture? Where there's a posterior wall fracture, posterior column fracture, then you will go for the posterior approach. If it is anterior wall or anterior column fracture, you will go for anterior approach. If it is T-type or complex type of the fracture, then you can use the dual approach. It depends what you are going to achieve, which side you are fixing.
I think that's the answer. Yeah, depends. You assess where the dislocation and the fracture.
No, but generally it's the posterior lip fracture.
Yes. Yeah. So if it is posterior lip fracture or a posterior column fracture, you will go with posterior approach.
Go with posterior approach.
Yeah.
That's what our ortho bullet says as well.
Yeah, I think that's a very reasonable.
Because I worked in St. George's with Martin Berger, and then I worked in QE Birmingham as well, which is a major trauma center. We have hip and pelvic surgeon, 2 pelvic surgeons. So I worked with both of them. So that is general approach.
Yeah. So basically, the approach what you're using is the posterior approach. Anyone else have to say anything, or we move on to knee?
They keep asking the question about is CT required. My attitude to this, and I think I'm sure everyone agrees in the mentor group, if you've reduced the hip, you need a CT to establish if there's a fragment in the joint or not. There's no other way of knowing if you've left a fragment in the joint.
Yeah, I think already Atal mentioned that.
Yeah, so there's no discussion about CT scan. It must be done.
Yes. Okay, so coming down to the last common dislocation is the knee dislocation, which, so these are the 4 general dislocations that we ask. If the knee dislocation comes, you know what they're going to ask. It's about the vascularity, it's about the reduction, and it's about the posterior approach to the knee, and it's about whether you put the X-fix first before the repair, or you just put the pins. So there is no right or wrong answers, but you need to be aware of all that. Knee dislocations, again, for a short tutorial, 5 minutes, knee dislocations generally can be of 2 types. High energy, if they are high energy, they are motor vehicle accident, commonly dashboard injury. Low energy, athletic injury, or in a morbidly obese patient. I have seen in a morbidly obese patient with very low rotational component and the knee dislocates. If the knee dislocates, generally it means 3 to 4 ligaments are disrupted. Vascular injury in all dislocations are 5 to 15%, and in 40 to 50% in posterior dislocations. Nerve injury is around 25%, and fractures are around 60%. Concomitant, it can be either femoral condyle or tibial condyle fracture. Okay, so the classification system, you don't need to know the very comprehensive Shannock classification system, although it's very, very very simple. However, you just need to know Shannock 4 means all 4 ligaments are gone. Shannock 3 is either medial collateral or lateral collateral. So 3 ligaments, ACL, PCL, either of the medial or lateral collateral is gone. And if it's 3 medial, it is related with vascular injury. If it's posterior, which are 25% of the normal dislocations, it is associated with arterial injury. If it's anterior, which is the most common, 30 to 50%, arterial injury are not as common. Why does the arterial injury happens? Because this everyone asks this question, and they ask me as well. It's not because it has something to do with the artery. It's because of tethering of the artery in the popliteal fossa. Proximally, the fibrous tunnel in the adductor hiatus tether it, and distally the fibrous tunnel in the soleus muscle tether it. So if you know this answer, this question was being asked directly to me, and you can then move forward. The classic controversy here is the measurement of the ankle brachial pressure index. Even the Miller has given this chart, and it says about if the ankle brachial pressure index is more than 0.9, you can do serial neurovascular check and do not do any vascular examination or any CT, arteriogram, or things like that, or duplex scan. However, some people like to say duplex scan. They are not wrong. Whoever say whatever, just have a system to defend yourself. I will always say, because of its high association to vascular injury, I will have a very low threshold of having a vascular scan in form of a duplex ultrasound scan. It is it's relatively safe investigation, and why don't we have it? Okay, all the rest is if you move forward from this point, you are coming to the treatment part, and if you come to the treatment part, then you are on the safe ground. For its treatment, initial management, all dislocation, this dislocation is not different than any other dislocation what we have discussed. Initial management involves immediate reduction and repetition of the documented neurovascular examination. Definitive treatment is always operative. Surgical indications include emergency surgical indication includes popliteal artery injury. It is related with compartment syndrome, open dislocation, irreducible dislocations. Irreducible dislocation, I have shown you the picture when you see when you see a puckering of the skin on the side. I don't know where it is gone now. Yes, over here. When you see a puckering of the side, and it means that it has buttonholed through the through the knee. It has buttonholed the knee capsule, and it's very unlikely that it's going to reduce itself or it's going to reduce close. So then you have to start thinking about open reduction, and however, the absolute indication of a surgical reduction is when you have a vascular injury. When you have a vascular injury, this is another classic exam answer. What would you do? You call for the vascular surgeon, you discuss the posterior approach while the vascular surgeon on the way, and I will say, I will put the pins before, put the patient semi-lateral and put the pins before, and don't tight the external fixator. As the vascular surgeon put the shunt in and repair the artery, I will tighten the external fixator and then reposition the patient to the front. After that, there is a controversy whether you will do a porphylectic fasciotomies or not. And some people actually like doing porphylectic fasciotomy, irrespective of whatever the compartment pressure is. However, most trauma surgeons just go by their gut feeling. If they see the leg is very sore, they do the leg is very swollen, they do the porphylectic fasciotomy, and some don't do it and wait for. But I wouldn't go to the fasciotomy part. I will say I will assess it and on case by case basis. However, in most cases which I have seen with arterial injury, they do porphylectic fasciotomies, and they do put the X-fix beforehand. They don't tight it because the initial arterial graft or arterial bypass or whatever the vascular surgeon put, it's very labile to any pressure and or any movement, and if you move it, it start leaking again because they use fine suture to suture it. The other thing to say here is remember the posterior approach, because that is another classic exam question where they say where they say, okay, the vascular surgeon is on its way. Can you please describe the posterior approach? So remember the posterior approach. I didn't put it on to keep to discuss it all. So when it comes to knee dislocation, remember three things: motor, whether it's high energy or low energy. Remember whether there is any skin changes suggestive of buttonholing through the capsule. Remember whether there is any arterial injury or not. Talk about interbrachial pressure index, ABPIs or ABIs. Talk about 0.9. Remember 0.9. But I will get a vascular study done. However, people very strongly sometimes say against it. As the new Miller says, there is no need if the ABPI is more than 0.9. But it's up to you, whatever you want to say. Then move on to the controversy of putting the X-fix first and urgent reduction as normal. And if you are reaching the posterior approach level and X-fix level, you are passing. So
in knee one, so it's a shunt, pin, and an X-fix, because you need to preserve or you need to maintain the vascular supply distally. So you do the shunt first, pins, and then X-fix, unless your vascular surgeon is away.
Good. So, Kashif, you have a viva question, yeah?
Yeah.
Is it ready?
Yeah.
Yeah. So our next candidate